All right, good morning. Good morning. Welcome to San Antonio and ASA 25. My name is Ron George. I'm a professor and director of obstetric anesthesia at Mount Sinai Hospital in Toronto, Canada, and currently the president of the Society for Obstetric Anesthesia and Perinatology. This morning we're going to talk a little bit about labor analgesia. Now, first of all, I do have some disclosures. I do have a direct relationship with the Canadian Journal of Anesthesia as an associate editor, and also with the International Journal of Obstetric Anesthesia on their editorial board. Now, we know what ideal analgesia looks like. We strive for it every day, but we also need to understand what the consequences of poor labor analgesia are. And that is dissatisfaction, traumatic birth experiences, which we want to try and prevent. Of course, the use of general anesthesia for cesarean delivery, neurological deficits. But more and more, we're seeing major public relations problems and legal difficulties for providers when it comes to poor delivery of labor analgesia. So we're going to hopefully try to shed some light on the evidence of what we can do to prevent these sort of options. Now, the modern day evolution of labor analgesia actually parallels changes in obstetric care of women. It always has. These are Simpson's forceps, the most widely used type of forceps. They were invented in 1845 by professor of midwifery, Dr. James Simpson, who then went on to experiment with chloroform and pioneered the use of labor analgesia. In the early 20th century, German doctors began offering something called Dämmerschlaf, or twilight sleep, evoking a fairy tale-like experience for the ideal delivery. And a combination of morphine and scopolamine, pregnant women were told they were going to not remember the horrible pain of childbirth. And then they took the show on the road, as this advertisement from a New York theater shows. Now, everyone in this room is well aware that labor pain is not static. Labor is not static. It's complex, it's dynamic, and one size cannot fit all. So we do have to have a menu of options for patients. We can and should deliver a patient-centric labor and delivery analgesic menu. Now, some of these options are not necessarily in our wheelhouse and may not be on the menu at your institution, but could be. We are not necessarily the providers of many of these options, but we also cannot be the barriers to these options because they do enable the provision of what the patient's experience is asking for. So we can help provide some guidance in our labor unit on how many of these options coexist with what we can provide in terms of labor analgesia. So this morning we're going to describe a little bit about the basic knowledge regarding non-pharmacological labor analgesic options. We're going to discuss the role of opioid PCA for labor analgesia, describe the current knowledge regarding labor epidural analgesia initiation, including CSEs, briefly on DPEs and then traditional epidurals, describe the current knowledge regarding PIEB, or programmed intermittent epidural bolus, with possible improvements in your labor analgesia, and then demonstrate some strategies to reduce and manage breakthrough pain. So a lot to cover. Now, on top of that, health disparities continue to affect racial and ethnic marginalized obstetric patients. My colleagues and I set to describe the racial and ethnic disparities in obstetric anesthesia via a scoping review of the recent literature, for which we presented an evidence map identifying knowledge gaps and propose a future research agenda. One study we highlighted in our scoping review revealed that in the state of New York, black patients were 45% less likely to receive labor analgesia. We need to better understand why this is. So please keep this in mind as we discuss the various modalities available for labor analgesia and how we can make those modalities available to all. Now, there are many non-pharmacological methods that claim to provide labor analgesia by reducing painful stimuli, activating peripheral sensory receptors, and inflating ascending pathways, and then enhancing descending pain modulating pathways. Evidence of their effectiveness and the efficacy of many of these modalities is limited to early stages of labor with small, methodologically flawed clinical trials, unfortunately. But you will have patients and healthcare providers who will subscribe to their benefits. And I'll just take a second to remind you, there is a QR code at the bottom of all the slides that will take you to all of the references that I'm talking about today, as well as a copy of the slides. So you'll see that throughout the presentation. Some of these options are used in labor and delivery. I have visited simple opportunities for patients to change positions and providing a comfortable room. A bed can go a long way to aiding in the management of pain in childbirth. Attempts to modulate the descending pathways are diverse and most recently very innovative, but still with very limited clinical evidence in this realm. Now, this is not the throw a picture of your pet up on the screen or your cute puppy to make people feel a bit happier, get the serotonin levels going. But these are actually the stars of a virtual reality study that was done. These lovely manatees floating in the water were actually used to help manage labor pain. This was a prospective randomized control crossover study. In other words, women opting for an unmedicated labor were randomly assigned to receive nothing or virtual reality manatees. And the numeric rating scores of the primary outcome for their worst pain intensity were significantly lower with virtual reality. So delightful manatees are probably better than nothing, but I'm sure that we need to do more research on what virtual reality modalities or images or scenes are actually going to be more effective with pain management in labor and childbirth. The class of modalities that possibly activate peripheral sensory receptors modulating conception are regularly used on the labor and delivery unit, and I suspect many of you see these in your units as well. Those include temperature modulation, hydrotherapy, acupressure, and TENS therapy, which is regularly used. Ultimately, there's limited efficacy of these modalities to treat the pain of childbirth, but we shouldn't dismiss them entirely, which can be obstructive to patients wanting to better understand how labor analgesia can be tailored to their desired birth experience. Pharmacological options have been around since the times of twilight sleep and chloroform. We just use them more innovatively now. In 2014, 25% of laboring women in the UK received an opioid analgesic. I'm willing to bet that this data is highly underestimated in the use of IM or IV opioids for labor in North America. Because of its unique pharmacology, drugs like remifentanil may be a plausible alternative to pethidine or meperidine and neuraxial analgesia. Remifentanil has some benefits. It's ultra-short-acting synthetic opioid with a context-sensitive time of approximately 3 minutes. The use of remifentanil in labor is typically off-label, but it may be a suitable alternative to neuraxial analgesia when it may be contraindicated or the patient just simply doesn't want a neuraxial anesthetic. Remifentanil readily crosses the placenta, but does undergo a rapid fetal elimination and metabolism. A typical PCEA dose or PCA dose with remifentanil is about 15 to 40 microgram bolus with a 2-minute lockout. One randomized trial comparing remifentanil PCA to inhaled nitrous oxide. In this small study, pain was assessed using a verbal 11-point scale. Pain intensity differences significantly favored remifentanil with 1.5 versus 5 for nitrous oxide, or 0.5. In another study, remifentanil PCA showed a greater reduction in VAS after 1 hour compared to fentanyl PCA, with no differences thereafter. Now, there is a small body of evidence, very limited amount of evidence, that suggests that remifentanil is superior to fentanyl or even safer than fentanyl, but we do have that feeling that it is probably of both of those ideals. They significantly provide better analgesia, or safer or to the fetus and the newborn. But you could argue that remifentanil does require a great deal more resources to ensure that it is safe. Recently, our nurses came out to me and asked, why do I need to be in the room with remifentanil? Why do I always have to provide one-on-one nursing? And we had a great discussion around some of the safety concerns with remifentanil. And we don't use it nearly as frequently in North America, so it does have, I think, even greater safety concerns. Now, there have been a series of studies who have attempted to reveal that remifentanil is reasonably alternative to epidural analgesia. However, it has been clear that remifentanil provides inferior analgesia compared with epidural analgesia. Despite this, we do have patients who have contraindications, and some people who we can't place an epidural catheter, and they want more choice. And frankly, the non-scientific literature demonizing labor analgesia or labor epidural analgesia contributes to people wanting choice. So remifentanil PCA has become a popular choice in some centers, resulting in 1/3 decline in this unit's epidural analgesia rate from 41% to 25%. Now, just by those rates of epidural use, you can tell that this wasn't in a North American center. Two things, of course: the centers that use it frequently deliver it better and do a better job of using it. And secondly, in this center where their epidural rate is only 45%, half of the epidural rate at many large centers in North America is going to be, that's about half the epidural rate in many large centers, including my own. So it is a very different modality when you're offering it in a center that has a limited amount of epidurals versus a prototypical North American center with our high epidural availability. Now, these results for the REMI PCA Safe Network, where they report on 5,700 cases of remifentanil PCA for labor analgesia. And despite a 25% oxygen desaturation rate, they feel that this modality can be safely applied. Of course, the caveat being that these centers use it frequently, very regularly, almost every day, and systematically, unlike many North American centers where we use it once or twice a month and have to be more guarded on its safety. It can certainly be used, but there are minimal safety standards that need to be in place and probably need to be described by some of our governing bodies here in North America. Epidural and spinal analgesia are by far the most effective modalities of childbirth pain relief, full stop. Quality neuraxial analgesia is safe for both the mother and the fetus. It does not interfere with the progress of labor and delivery. It delivers consistent pain relief with minimal undesirable side effects, but can also facilitate cesarean anesthesia. It can deliver satisfactory pain relief with less workload for top-ups and replacements of failed catheters. It delivers safe and effective anesthesia for our patients that are living with obesity and substance abuse and cardiac disease and all the other comorbidities that for which there's probably a benefit of having neuraxial analgesia and anesthesia. Now, most obstetric anesthesiologists who spend a prolonged period of time in labor and delivery, we all know that there's a benefit to having epidurals in our patients. And this study is one of those important studies in the last couple of years that highlights the value that obstetric anesthesiologists bring to the labor unit. This is a cohort of 600,000 patients in New York State that aimed to evaluate the reduction in severe maternal morbidity in women with neuraxial anesthesia. And the use of labor neuraxial anesthesia for vaginal delivery was associated with a 14% reduction in severe maternal morbidity. A similar article, somewhat duplicating these results, came out of the University of Glasgow, and it even made its way into National Geographic. It caught the eye of the lay press. And in this study, again, similar size project looking at a Scottish database which captured a great deal of all Scottish births over a long period of time. Having an epidural was associated with a 35% reduction in severe maternal morbidity in all women. And in fact, when you look at this curve and other data in the project, it gets even more effective in reducing morbidity when you use it in earlier gestations, and then in those cases where an epidural may be medically indicated because of some of those comorbidities I previously mentioned. Now, if we look at guidelines or standards of care that have been described by some of the leading organizations, including the Canadian Anesthesiologists Society, the American Society of Anesthesiologists, and the Royal College of Anesthetists, they highlight a few key things that we should be delivering within our labor analgesia programs. First, combined spinal epidurals should be easily available, readily available to all patients. Low concentration, local anesthetic solutions with opioids are probably the preferred solution. Patient-controlled epidural analgesia should be part of your regimen. And then effective neuraxial labor analgesia should be available on request and be responsive to the problems and complaints that may come from that. Again, the highly successful SOAP Centers of Excellence has been developed to recognize programs that strive to reach the benchmarks of quality labor analgesia. And they have additional suggestions that include the use of programmed intermittent epidural bolus and, of course, flexible epidural catheters. And we're going to touch on a lot of these topics during the course of the lecture. Now, let's first discuss how we opt to initiate our analgesic technique for labor. Specifically, we are going to look at the evidence for combined spinal epidurals and why you may want to choose that or a dural puncture epidural over a traditional epidural load. Now, how we initiate, what technique we choose, and the immediate implications for the patient has been talked about for many years. This is an article on combined spinal epidurals from 1999, a long time ago. I have put it up there because it highlights that the water cooler discussions, even though CSEs have evolved, labor analgesia has evolved, we still have the exact same discussions about CSEs. Not much has changed. People are fearful of the hypotension, fearful of the fetal heart rate abnormalities, but we all recognize it's fast and it's very reliable. This is an older study, but I think one of the better studies that compared combined spinal epidurals to epidurals, and it highlights some very key points, is why I continue to use it in my teaching. They hypothesized that it was the opioid and the use of the intrathecal sufentanil in a dose of 7.5 micrograms was more likely to induce non-reassuring fetal heart rate tracing than a small dose of a narcotic or opioid with a local anesthetic. So they did a 3-armed randomized trial. Primary outcome variables were the occurrence of non-reassuring fetal heart rate abnormalities and uterine hyperactivity. They had 3 groups, one with a traditional epidural initiation, one with, and 2 combined spinal epidurals groups, which one was only a high-dose opioid group, and the other was a more balanced traditional dosing of a combined spinal epidural that we are probably more used to seeing. One could also argue that in their group epidural, where they did a sham intrathecal puncture, that this was the first iteration of a dural puncture epidural in research. And so you could be combining DPEs with CSEs in this project. Now, a couple of key things. Labor analgesia was characteristically provided more rapidly with a combined spinal epidural. That would surprise no one. The epidural solution took roughly 30 minutes to get to the same equivalent level of analgesia as the combined spinal epidural groups. And it wasn't until that point where you saw that equivalent change in pain management, whereas the 2 CSE groups very rapidly reduced pain scores. Now, the incidence of non-reassuring fetal heart rate tracings were significantly more common after the exclusive high-dose intrathecal sufentanil group when compared to others. So the CSE with the local anesthetic and opioid combination, delivering that balanced anesthetic, achieving a type of analgesia that we all aim for, had no more frequent fetal heart rate abnormalities compared to the epidural group. And there was no significant difference in the cesarean delivery rate due to fetal heart rate, and none of the cesareans for fetal heart rate abnormalities in these patients occurred within the first hour of care. So this was the study that really gave people this thought that opioids were the cause of the fetal heart rate abnormalities. But I think when you look at this methodology, this is not the kind of study that can prove that any degrees of causation that it was the opioid-related problem with fetal heart rate. So if low-dose opioids or opioids we even think might be linked to it, how do we then deliver the lowest dose of opioids that's going to be effective for our combined spinal epidurals? In 2002, Kenneth Nelson at Wake Forest enrolled women in a study to determine the ED50 of intrathecal fentanyl for labor analgesia without local anesthesia. Now, the ED50 of intrathecal fentanyl for 60 minutes of labor analgesia was, too far. I'm going to go back here. Perfect. The ED50 for 60 minutes of intrathecal fentanyl was 18 micrograms, and this is without local anesthetic. But when I deliver a combined spinal epidural, my plan is not to deliver 60 minutes of labor analgesia. My plan is to deliver instant pain relief and then start using my epidural space as soon as possible. So I'm not looking for that 60 minutes. And I'm going to advocate in the next slide that we should be using a combination of the local anesthetic and the opioid. So these are what's the best evidence for local anesthetic? Well, I'm fortunate to work in Mount Sinai, where a very great group of colleagues did a couple of studies to answer this question a number of years ago. As we likely do not need the specificity that accompanies hyperbaric bupivacaine, an isobaric solution is likely more suitable. A couple of these studies which do highlight this. In this case, plain rather than hyperbaric solution of opioid provided a more suitable labor analgesia, a higher level of block, less hypotension. Secondly, in determining the ED95 for a combination of plain bupivacaine with 15 micrograms of fentanyl, a combination of those two led to a lower dose of 1.75 milligrams with fentanyl, provided rapid and reliable pain, alleviating it in a very timely manner. Now, there's still the concern of the fetal heart rate abnormalities. And tried to summarizing the impact of combined spinal epidurals, Haller and colleagues published a systematic review in 2016. And if you simply read the abstract, you might walk away thinking that combined spinal epidurals do carry a significant risk of non-reassuring fetal heart rate abnormalities. Nevertheless, the authors highlight the evidence is really inconclusive regarding any effect on fetal heart rate. First, many of the studies evaluating these concerns are old and use doses of medications that have not been advised for decades. Next, many of the studies had significant concerns for bias, with fetal heart rate monitoring not being described at all, monitoring of limited duration, their monitoring not even being defined within the methodology, and then the monitoring not being concealed or blinded within the randomized trial. So lots of methodological issues. So if you only include studies where they're using modern dosing of bupivacaine and epidural analgesia, only include studies where blinded outcome assessors would actually look at the fetal heart rate tracings, then you find there's no difference between the two neuraxial groups, meaning they could not conclude that a difference exists. And the conflicting results mean they could not find any difference between combined spinal epidurals and traditional epidurals as it relates to fetal heart rate abnormalities. So taking all of that information in and some of the dose finding studies, I think we need to extrapolate that information and come up with more patient-centered dosing of our combined spinal epidurals. And what I generally recommend is anywhere between 1.5 to 2 milligrams of isobaric bupivacaine with 10 mics of fentanyl. This will provide you rapid, good labor analgesia in a wide spectrum of patients. And then you will start your epidural, and those patients will remain comfortable throughout the early parts of labor. And recently, I had the pleasure to write an editorial with Dr. Ruth Landau on this topic after there was an interesting study published in Analgesia in the UK. And we suggest a more liberal use of combined spinal epidurals, thinking that it represents a truly patient-centric approach. It offers rapid onset, reliable early analgesia, and importantly, greater patient satisfaction and leads to a better patient experience. And these are not just technical details. They reflect what matters most to patients in the moment of labor, prompt and effective relief. That is what they want. So if you're doing CSCs, the other thing that people will always ask me, well, what about the untested catheter, the CSC myth? Well, Booth and colleagues addressed this myth while trying to show we can improve our failure rates of CSC initiation. They reviewed quality assurance records from about 2,400 labor neuraxial procedures with a primary outcome of catheter survival during labor analgesia. And the cumulative incidence of epidural failures was about 7% with CSCs and 12% for an epidural, traditional epidural. Failed catheters were more frequent in the epidural group, and they failed more frequently at cesarean delivery. Also, they failed later, delaying the recognition, delaying the management of good analgesia, and again, increasing the frustration and the poor labor experience of our patients. Lastly, on this topic, Lydia Grodin and colleagues hypothesized that there would be a difference in spinal analgesia success rates or epidural catheter efficacy between using saline versus air for loss of resistance. Didn't really find a big difference in that, but what they did end up highlighting is that the possible benefit of confirming the identification of the CSF and identifying midline epidural placement. There was no significant difference in their loss of resistance technique, for which they were primarily studying, but when they evaluated the attempt to do a CSC for which they did not detect CSF, the epidural catheter replacement rate was significantly higher, which was part of the movement in those days to understand how the benefits of puncturing the dura might aid us, and probably was also some of the thinking when we were talking about the dural puncture epidural. Now, the major impetus for the DPE in the latest development in the evolution of labor epidural techniques has been to try and reduce the complications of CSEs if we thought the evidence did show that, but also delivering a safe, effective, and maybe more rapid analgesia with better sacral spread. And with a DPE, the spinal needle is, again, just like a CSE, inserted through the shaft of the needle to create a dural puncture with CSE conformation. However, no medications are directly administered through the spinal needle, and there is belief that there may be some translocation through that very tiny spinal needle. Keep in mind, all of the medications eventually translocate through the dura to their point of action. Now, I'll only mention a couple of studies on DPE-specific trials, and I'll mention this one from Dr. Chow and Dr. Sen because it's probably one of the better done methodologically and demonstrates some of the impact. A total of 120 parturients in early labor were randomly assigned to a traditional epidural, a DPE, or a combined spinal epidural. You can see their initial dosing for all of their options there, and the primary outcome was the time to a numeric pain scale less than or equal to 1. Now, there was no significant difference in the pain score to less than or equal to 1 between a dural puncture epidural and a traditional epidural. And the DPE achieved that pain score significantly slower than a combined spinal epidural. In this slide, you can visualize the variance of the interquartile range that they published, and it solidly shows that for the most part, combined spinal epidurals work. Compared to the CSC technique, the dural puncture epidural and the epidural technique had no difference in fetal decelerations, but did have a lesser incidence of fetal heart rate conversion from a category 1 to a category 2 tracing, which is, questionable whether it has any clinical significance. But what you can see in these bars is also that a large number of patients in both the DPE and the epidural group never reached their target pain relief level after 2 hours in the study. Lastly, in the DPE research, this is a randomized trial using a biased coin sequential allocation method to achieve or determine the minimally effective dose of 20 mils of bupivacaine to achieve initial labor analgesia in 90% of women, and was termed to be 29 milligrams with the DPE technique and 45 milligrams with the epidural technique, which indicates that the DPE reduced the bupivacaine dose by 35%. So that's like giving 0.22% versus 0.145% in your epidural load to initiate good labor analgesia. Nevertheless, that sounds promising. Nevertheless, the DPE and the epidural group still had a number of patients who never achieved their targets of labor epidural pain relief. And that should be concerning to all of us. So, could you do a simple DPE rather than a CSE? Well, Dr. Singh and his colleagues just published a well-written, and this is just published a couple of months ago, a well-written systematic review on this very topic. They took all laboring patients, looked at patients who were receiving a DPE for labor analgesia compared to a conventional epidural labor analgesia, and they were looking primarily at the time to require adequate analgesia. Secondary outcomes being our traditional unilateral block, number of manual top-ups, and of course epidural replacement. Now, however, many of these studies had a significantly high risk of bias when they did the bias assessment. In short, if you look at their results, the DPE provided adequate analgesia, but it was only 3 minutes faster than a conventional traditional epidural. It was associated with less unilateral blocks, but didn't result in any more top-ups or the need to replace the catheter, so questionable whether the unilateral was that concerning to them. And I do not feel that DPE has much of a utility in most of our labor units, and every patient who should receive a patient-specific, patient-centered dosing of a combined spinal epidural will get all of the benefits of a DPE and so much more, as well as a likely effective epidural catheter moving forward. So once you start your epidural, how are we then going to maintain it once we got them off to a great start? So in the past 30 to 35 years, epidural labor analgesia is initiated and had been maintained with manual clinician boluses, and then delivered by pumps, most commonly a continuous infusion of local anesthetics and opioids. We then saw an advent of patient-controlled epidural analgesia to supplement their infusions and provide some patient input. And now we frequently see programmed intermittent boluses accompanied by PCEA. Now, most recently, there's also been some work combining continuous infusions with PIEB and PCEA, and I believe in the future we're going to see more of these studies. There's not really a lot to talk about on that topic now, but when you think about how AI and changes to our pumps are about to happen, I think we'll start to see a mixture of all these modalities, which will enable us to be more active in the dynamic process of labor epidural analgesia, as labor is dynamic and ever-changing. Our experience with PCA has shown that patients with PCEA bolus analgesia are less likely to require additional analgesic interventions, require lower doses of local anesthetics, have higher satisfaction scores, and have less motor block. And this is a bit old data, but we've utilized all of these modalities in our new PIB regimens, and we see the similar outcomes. Concurrently with how we change how we deliver, we've changed what we deliver. Most of us are probably moved on to lower concentration local anesthetics. When you compare high concentration local anesthetics to low concentration epidural analgesia, there may be a reduction of instrumental vaginal delivery, or the thought was that there may be a reduction in instrumental vaginal delivery at one point. Theorized that we get less motor blockade and then reduce the or not get in the way of that bearing down effect and during the second stage of labor. Subsequently, however, there's been more systematic reviews and meta-analysis that suggest that this effect might not have the impact on obstetric outcomes that we once thought. But it does confirm that low concentration labor epidural analgesia facilitates higher volumes and seem to benefit the patient in childbirth. And given the wide range of nociceptive inputs, while there are no benefits to higher concentration labor epidural, we must and should continue to move towards the lower concentration, higher safety factor local anesthetics. The high volume of the low concentration is important because spread, as we are all aware in the epidural space, is critically important to the effectiveness of our labor epidurals. And this simple litmus test example reminds us of the effectiveness of bolusing epidurals versus a slow continuous infusion in the epidural space. The effectiveness of epidural analgesia requires that spread, and this simple study of looking at 3.5 mils delivered over 1 minute every 20 minutes versus 10.5 mils per hour simply shows that spread, which has then been confirmed in cadaveric studies. PIEB is an automated method of administering epidural local anesthetic solution boluses at fixed scheduled time intervals. PIEB is used as an alternative to continuous infusion. In the future, we may see them used together. It has been proposed that the delivery of the same dose of local anesthetics as an intermittent bolus is a more effective method than maintaining it with a continuous infusion. And again, this is an image out of a textbook that just demonstrates those potential spaces of the epidural space. And what our epidural solution is doing is a sort of fluid dissection in the epidural space, creating those more continuous spaces that exist rather than these discontinuous pyramids of opportune space in the epidural area. Now, there has been 27 randomized trials that were included in a systematic review and meta-analysis on PIB, and the need for additional local anesthetic or anesthetic interventions or breakthrough pain was significantly reduced with PIB by about 38%. Once you have PIB, the common question is, what do we do? How do we set these pumps? And there's been a lot of research that has provided us some guidance on this topic. The culmination of many trials, including these 4, confirmed that there is no real advantage of higher concentrations of local anesthetic over those larger volumes of the low concentration. And secondly, that the most reasonably starting point for your PIB pumps might be a PIB volume of roughly 10 mils in an interval of 40 minutes. The group in Toronto has been investigating whether or not and how these sensory blocks are impacted by these PIB cycles. And the partial sensory level, the upper part of our block when we're testing it, when you have that just slight change to a normal to a partial block, and the PSL and the complete spinal or complete sensory level where you get that dense anesthetic block were achieved around 100 minutes into the PIB delivery. So you do see a slow gradual increase in the level of the block when you're using PIEB, but it seems to settle out after about 100 minutes, and we do tend to see slightly higher blocks. There was no significant variation in the CSL or PSL with the cycles between the second or third or the fourth program bolus. Once they reach those peak levels and it's been established, there doesn't seem to be a lot of variation in that. We subsequently conducted a prospective cohort study in patients that established labor epidural analgesia who were experiencing pain in the first stage of labor, who had requested rescue analgesia. And we compared these partial sensory and complete sensory levels to ice and pinprick at a time when they were experiencing pain. And patients seemed to be experiencing pain during the maintenance phase of epidural analgesia when the complete spinal or complete sensory loss level goes below T10. And when we bring it up above T10, we seem to resolve the pain. And we're going to be doing some more work looking at how we can alter this and, again, the impact that PIB and PCEA has on these. So when you're talking about PIB, I think it does provide the modern way we should be delivering labor epidural analgesia. It does provide improved maternal satisfaction. We use less local anesthetic overall, less anesthetic interventions. And I think there's a lot of opportunity for us to better understand how we can engage our patients with labor epidurals, as well as delivering maybe a more personalized form of labor epidural analgesia in the future. Despite that, there's probably only 50% of centers that are using PIB now, and that's probably partially related to the pumps and the ability and access to pumps that can deliver it, and so hopefully we'll start to see this become more universally used. Lastly, I'm going to talk a little bit about breakthrough pain and how you manage it with labor epidurals. Now, despite starting off well with a combined spinal epidural, despite using low concentration epidural solutions and using high volumes, PIB maintenance labor epidural analgesia can still fail. If failure is the outcome, I'd much prefer to identify this earlier than later, and I'd much prefer to identify it in the labor room rather than the operating theater, of course. And the degree of urgency is highly predictive of epidural conversion failure. However, it is also well recognized that general anesthesia can sometimes often be preferable and when time is of the essence. Several studies have suggested that the initiation of neuraxial labor analgesia by obstetric anesthesiologists decreases the incidence of epidural conversion failure. This is highly likely related to these individuals spend a great deal more time on a labor unit, and places that have dedicated obstetric anesthesiologists probably have different resources and different staffing models that allow them to do this. And so this is something that the SOAP Centers of Excellence and ASA, and as they work on this workforce discussion of how we're going to staff labor units in the future, we need to better understand the kind of care and value that we bring to the labor units. Now, non-specialists anesthesiologists will use general anesthesia more frequently. This has been well described in numerous research articles, and obstetric anesthesiologists are more willing to manipulate and push the boundaries of epidural catheters because of just altered comfort levels, and that's not unusual to expect. No one is likely surprised at the number of times you're called into the room or troubleshoot a catheter to administer additional medications is associated with catheter failure. To discuss the risk when consenting, I definitely would suggest that you need to discuss these risks of epidural failure and manipulation of your catheters, top-up medications when you're doing your consent for your epidural process. Currently, the data to conclude that epidural catheters placed as part of CSEs for labor analgesia are superior, but the data now with DPE techniques and piercing of the dura to confirm placement may alter your perception of the data, and changes that the management of labor epidurals in the past have swayed towards using a dural puncture epidural technique or a combined spinal epidural technique to better identify our epidural space, and there is an association with better catheters in the labor unit and in the operating theater. Nevertheless, I think I always suggest trust yourself as a skilled clinician, skilled provider. Occasionally, you will not achieve a dural puncture through a CSE needle, and it may not mean that your catheter is not going to work, but you need to kind of judge that on a per patient basis. If I have a good loss of resistance, everything else felt very normal, but I don't happen to get CSF, I may not opt to go to another level. I'll thread the catheter and provide as best analgesia as I can through the epidural catheter, but always keep in mind that that catheter now is associated with a higher failure rate than if I had gotten CSF. On the lines, or in the line of epidural troubleshooting and management of labor analgesia, this is a consensus paper that came from Dr. Nicholas Broglie in Spain and his colleagues from the European Society of Anesthesia, and they summarize and come up with some consensus of how things should be managed. It's a really interesting paper. There's not a lot of concrete, this is how you should do it in there, but I think there's a lot of good advice for anesthesiologists. Some of it is that we need to take responsibility for this. If we put in catheters, we need to be seeing and taking care of these patients on an ongoing basis. They need responsive care throughout the course of labor. We need to do regular and objective assessments of pain in labor. We need to, again, demonstrate the value that anesthesiologists bring to a labor unit. And of course, we all should have in our centers some algorithm or protocol to drive how we're going to manage failed epidural analgesia. Now, there are a lot of algorithms out there, and I think they all need to be constructed or taken home and constructed in a context-sensitive manner to where you're working, because not every algorithm can then just be dropped in the middle of your center. On the right side, we've got an algorithm from Vanderbilt and Hollyendy where they compared their pre-algorithm period, and there was an increase in the rate of epidural replacements occurring after the algorithm, and sensing that they were managing epidurals a lot more effectively with the use of this algorithm. So aggressive assessment and managing of the challenges to reduce the negative consequences of labor or poor labor analgesia should be advocated for. Now, this is an algorithm that I try to teach, one that I have taken over the years and evolved with different colleagues depending on the setting that I'm working in. And breakthrough pain should be managed in a logical, stepwise workflow to promptly diagnose the cause and institute appropriate treatments. Now, we suggest the formulation of departmental guidelines that incorporate your local practices, problem-solving algorithms that reflect your local resources and manpower. Management would involve assessing the nature, severity, and location of the pain, of course, as well as the contributing factors that increase pain, including rapid labor progression and the use of uterotonics for induction or augmentation of labor. Now, this algorithm emphasizes PCEA education and re-education. All too frequently, the patients have not or do not feel the ability to safely use PCEA. So you do have to educate the patients on them and educate them that it is part of the modality. It is not a rescue. It is just part of the modality that we can deliver safe, effective analgesia. Again, emphasizing to start strong and to start the patients off with a good initiation of your labor epidurals, and I hope I can mention to use more CSEs. But then these need to be checked within 1 hour. Did you achieve primary analgesia in these patients? We need to evaluate this not only within the hour, but then again frequently throughout the course of labor. Currently, we assess our epidurals maybe every shift, but I think that needs to be a shift change, but it probably needs to be a bit more frequently. It also needs to interact with how your nurses check and document checks of your epidural analgesia, which can be very helpful, but also if they're not being done consistently can be very unhelpful. It also emphasizes pump interrogation. And what I mean by that is when you get called into the room, I think it is necessary to evaluate your pump. Not only that it's working effectively, because pumps do fail, I've seen it numerous times, but you want to again look at, is it delivering the analgesia you thought it was? Is it delivering the right volumes? Errors occur. Is the PCEA being used, which you can generally, with most of the current pumps, quickly evaluate in some of the graphs that are available. And if the patients are not using PCEA, perhaps this is another opportunity to educate them on the benefits of that. And of course, we need to demonstrate the value we bring and to demonstrate the work we're doing and make sure that we document this, not only for demonstrating value, but to also, when we hand over these catheters to our colleagues, that they're not caught in the doing this whole cycle again. As you move in the other part of this algorithm, there is the sort of assessment of what the issues might be. And as you move from right to left, left to right, as you move to the right, the likelihood of the catheter working improves. So, the green happy person on the side, these are catheters that we can generally fix pretty easily. Yellows are getting the sort of sometimes asymmetrical, a very low block. They may need some work. And the red ones are the ones you need to be aware of and be very cautious of. And if I don't fix a red catheter really quickly, it gets replaced really quickly. One of the interesting things that I stuck in the algorithm for the sort of middle ground is you do see people occasionally getting, or regularly getting called in for a low, maybe asymmetrical block, and this happens repeatedly. And I think this is, again, an opportunity where we should be then looking at our pump and maybe changing our settings. And it's not uncommon for me to go in and change my PIEB interval from 40 minutes down to 30 minutes, thinking this patient needs a little bit more volume over time. Or perhaps I may alter my PCEA dose from 5 mils up to 7 mils. These are all things that I think we should be doing as we watch labor evolve in these patients and use the subjective and objective evaluation of our patients in labor. As I mentioned, we need to empower our patients to use the PCEA properly. We need to ensure that this is part of our means of delivering effective and responsive neuraxial labor analgesia. We call this patient-controlled analgesia, but we all know the truth that we control it. They just simply push a button, and it's not really that responsive. So I think in the future, as we move towards maybe a more patient-responsive analgesic algorithms, we may see the use of these buttons in a different manner and in a different light. What about some of the different adjuncts that you may want to use to help out your labor epidurals? Well, one option might be the addition of epinephrine, an old agent that has been used for many years over epidural analgesia. And I hadn't used it a lot until one of my stint when I was working at UCSF in California, where this was a common practice where we would use it, and began to favor it in those troubling settings as one option you had in your quiver to pull out and help you out on difficult evenings. And so the addition of epinephrine, 1 in 300,000, significantly reduces the minimal local anesthetic concentration of bupivacaine by about 30%. It increases the efficacy of levobupivacaine and sufentanil during epidural labor analgesia and reduced hourly drug consumption, rescue dosing, and pain scores. And lastly, epinephrine did increase the mean duration of satisfactory analgesia prior to its use in control groups. What this means is you're adding epinephrine, and it is going to essentially turn your 0.0625% epidural solution into a 0.08% solution, roughly. It's just essentially making it emulate a higher concentration solution. Naturally, when you get a higher concentration solution, one thing that's going to happen is your likelihood of some motor blockade is going to increase. So that's one of the downsides of using epinephrine. The other newer agents that are frequently getting talked about are clonidine and dexmedetomidine. Now, clonidine, 60 micrograms, can decrease the minimal local anesthetic concentration of ropivacaine boluses to levels we'd expect with the addition of an opioid. To me, and some of the research has always suggested that the addition of 60 to 100 mics of clonidine is almost like giving 60 to 100 mics of fentanyl, but perhaps with a bit of a longer effect. Epidural clonidine, 100 micrograms, however, was not superior to fentanyl 100 micrograms, but relatively similar approach or similar effect that it had when using it as part of a co-administration with bupivacaine 0.125% to treat top-ups. Now, the differences in the EC50, or the effective concentration 50 of ropivacaine with dexmedetomidine, was not statistically significant. And this is one of the few studies that are methodologically done well with the use of dexmedetomidine in the epidural space. And I don't want to talk a whole lot more about it because I don't think the evidence really has panned out or been delivered to us yet. And I hope over the next couple of years we'll see a little bit more evidence on the use of agents like dexmedetomidine, because I know it is becoming very frequently used, but again, it's off-label use, and the evidence is very sparse that it actually has a benefit to patients. Very anecdotal data currently. So, the Centers of Excellence for Anesthesia Care of Obstetric Patients does include low concentration local anesthetic solutions with opioids, Combined spinal epidural analgesia should be available on your units for all patients. And I'm a big advocate of CSEs, not only because of the good analgesia, but it is the most flexible modality that I have on my busy labor unit that I use every day for complex cesareans, complex labor analgesia issues. And the more you do CSEs, and it's, to those, some people who don't do them frequently don't think it's that hard. I see people who do it very infrequently fail at it a lot because there is a little bit of a technique to it. There's no perfect needle combination out there that just works every single time. And so you do need to know how to troubleshoot these situations and work with the equipment you have. So the more you use it in labor analgesia, the more effective you'll use it in those complex operative environments on labor and delivery. I think we need to use patient-controlled epidural analgesia in combination with our programmed intermittent epidural boluses. The two of them deliver what we now have as the best way of delivering labor epidural analgesia, where we can use low concentration local anesthetics and achieve labor analgesia with minimal motor blockade, minimal impact on the progress of labor, and deliver the best patient experience that we can currently. And lastly, I re-emphasize the fact that we have to have a system of management within our labor units. You cannot just set it and forget it, if anybody remembers the Ron Popeil commercials. It's not a set it and forget it kind of thing. You have to set it and reevaluate it, revisit it, and be focused on delivering that value that anesthesiologists need to deliver to labor units across the world, but across North America, of course. Good. So, what are my sort of major take-home points if I was to tell somebody how to go into the labor unit? One, start strong. Combined spinal epidural using 1.5 milligrams of bupivacaine isobaric with 10 micrograms of fentanyl. This will get your patients comfortable by the time you're packing up your kit in the room and just starting your record keeping. Patients will already be significantly in less discomfort. Maintenance, I think using 0.0625 to 0.08 in a high volume tertiary center right now is a necessity. It delivers a good patient experience with less motor blockade and can be done with a reasonable amount of workload. If you're going to use the PIB, then my suggestion would be the 8 mil every 40 minutes. I think that delivers a safe, effective amount of labor epidural analgesia, and then incorporate PCEA into the process. It is not a rescue. It is something that should be used on a regular basis. And then the other thing I didn't touch on in the prior is the idea of the next bolus. So those familiar with PIB know that you have to tell the pump when to give the first bolus. Too frequently, we're putting that bolus too far off of when you started your epidural, and it should be sooner. Especially with a combined spinal epidural, I'm aiming to give rapid analgesia, but not analgesia that's going to last for 60 minutes. So I set my pump to start its first PCEA low concentration bolus 15 minutes after my combined spinal epidural. And this provides rapid analgesia and continuous analgesia for the first early phases of your epidural process. And lastly, I do encourage everyone to evaluate their epidurals within 60 minutes of placement. Primary failure is something you really want to avoid. Secondary failure, i.e. failure hours after it's in, maybe due to movement of the catheter, are even harder to get away with or fix. But primary failure we should get on top of as soon as possible and deal with that as soon as possible. So quality labor epidural analgesia has many faces, many options are desired and sought after. So when providing neuraxial analgesia, our CSEs are underutilized. We should consider PIB. I'm still unsure of where the dural puncture epidural fits in the course of labor analgesia. I think we have to have plans to evaluate and respond quickly to patients' needs. And I'd encourage everyone to have a look at the ASA quality metrics on labor analgesia. And are you collecting those at your site? And how can you incorporate them into the obstetrician's plans to incorporate these metrics? Many times, quality metrics are being captured on behalf of the obstetric cohort of patients, and we need to start to incorporate anesthesia metrics as part of that institutionally collected data to help guide you as anesthesiologists delivering the best care possible. So I'm going to have time for a couple of minutes, but a couple of questions. But I wanted to highlight two things. One, the Painless Push is a soap product now, our patient-facing website for patient information. This is a wonderful resource, translated into 100 or more languages, I think, a lot. And it's a great resource. You know, share this with your patients, share this with your colleagues, share it with your institutions so that they can distribute it to their patients. It is a wonderful resource. It's going to evolve over time, and we'll be keeping it updated. And it's something we've been working on for many years, so it is a great resource. And lastly, I hope to see all of you in Montreal. Come up to Canada. Your American dollars will go a long way. You'll get some great Montreal bagels. They are better than New York bagels. I'm telling you, that's the truth. And you'll just get to see a bit of almost a European flair in a North American city. So it's going to be a wonderful meeting, and I hope to see you all in Montreal in May. So thank you very much. And again, if you didn't get the QR code and you want a copy of the slides and the references, I'll email you the link. It's a Dropbox folder. We'll have everything in there for you. Yes?
Hi, fantastic talk. Thank you very much. Can you talk about the difference in spinal needle gauge with CSE and DPE and the difference in analgesia?
So it's a great question, complex one though. I use a 27 gauge needle as part of our CSE kit. I just find the dexterity of it and administration of it seems to work well with our current setup. We know that with spinals, if you're doing a spinal, a 25 gauge versus a 27 gauge, we seem to have more failures with 27 gauges for spinal anesthesia for cesarean delivery, which is why I currently use a 25 gauge in most of my spinals for cesarean delivery. But I don't believe there's any available data on failures versus 27 to 25. I suspect there probably is maybe a small degree of failure with the 27 gauge. I erred on the side of 27 when I was putting our kit together, mainly because I like the feel of it. But part of it is even though the risks of post-dural puncture headache, the biggest part of the risk is the TUI, right? So if you're doing a CSE, you already took this patient and put them in a risk category of getting an epidural. That's where the biggest risk is. And undiscovered, unrecognized dural punctures do happen. So I don't think you can change your post-dural puncture rate of a CSE because the biggest risk is the TUI by doing between a 25 and a 27. But there were some in my department that insisted we should have a 27 gauge. And I think that made some sense. But there probably is a small amount of failures of the CSE portion because you're using a 27 gauge. But thankfully, in these situations, you have your catheter that is going to support you. So if I don't achieve the analgesia that I expect with my spinal portion right away, first thing I do is hook up my pump and hit the PCA button before I leave the room. So if they're 5 to 7 minutes, if that patient's not at the comfort level I want, I start using the epidural space even sooner to try and achieve that level of comfort. I hope that answers your question.
Good morning. My name's Tony from Boston. Quick question. The 1.5 milligrams of bupi with 10 of fentanyl that you use, are you compounding that right at the patient, or is pharmacy providing that for you?
We're mixing it ourselves. I don't have a pharmacy that will be able to do that. I know there are some centers that do that. The study I presented from Dr. Chow and Dr. Sen on the DPE CSE combination, I know they were using the solution that comes up in their pump, and they were actually just drawing it out of the bag of the mixed solution. So I mean, I think there's a lot of ways to do that, but
infection there. So.
Yeah. You know, I think you need to work with your pharmacy, and some pharmacies do have better compounding setups and where they do recognize that they're going to be saving actually a lot of money over time. I do feel very bad about taking a very small little dose out of a vial of 0.25%, and I've had this discussion with my pharmacy who does compound some things. For instance, I have small little 1cc syringes of Epimorph in my cart that I use with our spinals that they prepare for us to break up the big Duromorph for epidural morphine that they break up for us, which has been very cost effective. So trying to convince them that to build up their resources so that we can do that with other options such as a combined spinal epidural would be very helpful. We are also having an issue because we don't have an in-room Pyxis or anything like that, so the nurses go and grab the fentanyl and we have an issue with tracking of that vial of fentanyl, given you're only taking 10 mics out of it. So I'm using all of those to leverage to hopefully get to what you're describing at some point in the future. Any other questions I can answer before people? I'm going to hang around for a couple of minutes afterwards too, if people want to come up and have a chat. I always like to hear what people are doing for labor analgesia at their institute and see if they have any questions.
I have one more question since nobody else is stepping up to the mic here. When you do intrathecal catheters and you thread them, how many centimeters do you thread the catheter in?
Intrathecal catheters?
Right.
I am not a proponent of threading an intrathecal catheter for when I have an unintentional dural puncture. But if I had to, because sometimes there is cases where you need to, I thread them just like I do my epidural catheters, and I leave 5 centimeters in the space. Try to. Good. All right. Well, thank you so much for your attention this morning. Thank you very much.